So thank you for that important question. Transcatheter aortic valve replacement is increasing in the numbers of procedures. It's becoming the treatment of choice for most patients with severe aortic stenosis, spanning the risk of low to even very high risk patients as an alternative to surgical aortic valve replacement. And in many ways, really a great option for extremely high risk and intermediate to high risk and even the low risk patients. And as such, it's really important to make sure that, we understand if at all there's any kind of a need for special pharmacology, antiplatelet regimens after TAVR. And at the moment, when we started TAVR, most patients just got on aspirin clopidogrel therapy for 3 months, and the guidelines are kind of saying 3 to 6 months aspirin clopidogrel, and those patients requiring an oral anticoagulant to also receive that, but judiciously. Obviously, triple therapy would be very difficult in these patients, and in those patients, usually they drop the aspirin. But over the years now, with the very important trial, popular TAVI, where they looked at both with or without an oral anticoagulation, less seems to be more. And really, the need for a dual antiplatelet therapy is coming into question. The Galileo study really did evaluate the role of a novel oral anticoagulant, rivaroxaban, at a modified dose in patients undergoing TAVR versus an antiplatelet strategy. And the trial was stopped early due to more harm in the anticoagulation group. And I think it's important to understand that these are extremely high-risk patients, because even though we deem them low risk for surgical, like we say, low-risk patients, they're not really low risk. The average age is over the age of 70, sometimes 80. So they're at a very high risk for bleeding complications, and as such, we have to really understand how to tailor therapy for these patients. So for now, it seems to be that less is more, and a single antiplatelet regimen is what's being used, but the guidelines haven't really updated their guidelines. And I think this leaves room for some prospective randomized studies in the future to evaluate the role of dual antiplatelet therapies versus single. So combining, as I said, that in patients who require oral anticoagulants because they have atrial fibrillation, the risk of stroke is really, really high. So balancing the risk of stroke versus bleeding and choosing the right combination therapy in these patients is extremely crucial. And in most cases, I think making sure that the oral anticoagulant is given to the patient, mostly a novel oral anticoagulant, because that's what they're usually treated with, and making sure that we minimize bleeding by not adding too much antiplatelet regimens. Now, if the patient had a stent just before the procedure or requires a stent, there has to be some short duration of antiplatelet treatments, but less is more, especially in these patients with oral anticoagulants. But we have to make sure we don't ration the oral anticoagulant use, because it's really important for stroke prevention. The other thing for stroke prevention is during the procedure is the use of distal embolic devices and embolic protection devices. And we are not really the data is not yet clear whether there is a stroke reduction, and a very large clinical trial is underway right now examining the role of distal embolic protection devices in TAVR. So the incidence of valve thrombosis or valve leaflet mobility, decreased valve leaflet mobility or restriction in mobility, is actually not so rare, but could be somewhere in the order of 10 or 15% when we start to see increasing gradients and decreased valve mobility, especially on 4DCT. And that was sort of the work that Raj Makkar and his team did in Sinai, where they evaluated this across all valves, also surgical valves, showing that if you give anticoagulants, you can resolve this. And in fact, in the Galileo 4D CT sub-study, we did show that rivaroxaban was associated with a reduced of valve immobility or valve thrombosis or valve-related issues. But remember, Galileo was stopped because of the bleeding issue. So we have to still work hard to see where's that balance. And that role of subclinical valve thrombosis or subclinical valve leaflet decreased mobility really under investigation now. We don't really know. Some of the sub-studies did show some levels of subclinical valve thrombosis or valve decreased mobility, and its effect on long-term durability of the valve is something that we have to kind of look out for. But for now, it seems like in the early follow-up that it seems like we don't really have a full answer on what to do, although some of these anecdotal experiences and retrospective data have shown that giving oral anticoagulants to these patients can resolve the mobility issue, which kind of tells you that there could be some thrombin, platelet, or thrombus-related activity going on in the valve at that place. And so, again, we still have to continue to evaluate this arena. So yeah, as I said, the future I believe is extremely bright in TAVR and TAVR pharmacology. We're working very, very hard. There is the Atlantis trial that's coming that's going to be extremely informative. In Atlantis, apixaban is being evaluated at the full dose with or without atrial fibrillation in patients undergoing TAVR. We're really looking out for that study, hopefully coming at ACC. The Envisage study, which is patients with AFib, is evaluating the role of a novel oral anticoagulant, edoxaban, compared to warfarin in these patients undergoing TAVR. So far, so good. We're waiting for the results. Hopefully, we can see what the evaluation of those of that particular study is. These are both very large scale studies. And then larger major studies, registry-based studies are being planned. So I think we absolutely must find what's the optimal treatment in whom, why, when, how. And I think there's a lot of research in the future that's going to hopefully evaluate this.